Ovarian hyperstimulation syndrome. How to prevent? What is it? It is an iatrogenic condition induced by the clinician. Exact pathogenesis is not clear. High E2 is the underlying factor. Severity. In its severest forms, it is complicated by hemoconcentration, venous thrombosis, electrolyte imbalance and renal and hepatic failure. Classification of OHSS. Mild form of ovarian hyperstimulation is almost always with ovulation induction. Life-threatening. Severe OHSS is a serious complication of ovulation induction. Hepatorenal. How to prevent? Steps before stimulation, steps during stimulation, steps on impending severe OHSS. Steps before stimulation. Identifying the patients at risk before ovulation. PCOD patient's history of previous severe OHSS. Before stimulation. After stimulation. Steps during stimulation. Be aware of large number of developing follicles, more than 20, be aware of high E2 level, more than 3000, on approaching day of SEG. If any or both, then what to do? Steps during stimulation. Gonadotrophin dose according to age and body weight. Young age less than 25 octoseconds, 2 amp. Thin woman less than 60 kilograms, 2 amp. Low gonadotropin doses. Stop HMG and continue downregulation. This is the only complete prevention. Abulga and Mansoura, 2003. Not a preferred choice for both doctors or patients. Cryopreservation of embryos. Coasting. Mature follicles can survive for a few days without exogenous FSH, HMG, while small follicles will undergo apoptosis, necrosis. Graphian follicle 1, oocyte 5. The granulosa cells aspirated from coasted patients showed a ratio in favor of apoptosis, especially in smaller follicles. The EGF protein secretion and gene expression in granulosa cells, especially in small and medium follicles, were reduced in coasting 20. What happens when you start coasting? Follicular growth will continue with the same rate. Clinical and practical tips. The Egyptian IVF-ET Center experience when to stop gonadotropins. When the leading follicles reach 16 mm. How many days? Till the A2 drops to less than 3000 pg, ml. Fluker et al., 2000, O'Harto et al., 2000. The number of days of coasting is not the key issue. Dose of HCG? 5000 is enough. Special laboratory aspects? Extra time to identify the oocytes from the follicular fluid. The Egyptian IVF-ET Center. Problems with coasting. Occasionally A2 drops markedly to very low levels and cycle is cancelled. Difficulty in identification of oocytes in aspirated follicular fluid after prolonged coasting. However, pregnancy rates appear to decrease while coasting during prolonged gonadotropin. Why? Perhaps because suspending gonadotropins may starve the granulosa cells at a critical time of oocyte development when LH is necessary. The role of GnRH antagonist in the prevention of OHSS. GnRH antagonist. GnRH antagonists. A unique idea administration when follicle reach 16 mm. Continue HMG. Step down protocol. Monitor by E2 not more than 3 days. Value. Allow continued stimulation while rapidly decreasing the A2 level to a range that is clinically acceptable. Serum GnRH antagonist versus GnRH agonist in patients at high risk of OHSS. Metformin positively modulates the reproductive axis, namely GnRH-LH episodic release, Shani et al., 2004. Evidence. Metformin and OHSS. It is now our routine to give metformin with the start of downregulation till the day of HCG. Possible mechanisms. Lower intra-ovarian androgen levels. Improves endothelial function. The use of metformin for women with PCOS. Systematic. Luteal support. Avoid HCG. Progesterone only. Close observation. OHSS is a preventable disease. What if it happens? How to manage? Always remember. Investigations: hematocrit, liver functions, creatinine. Fluid monitoring. Always remember. Echo job. May do paracentesis, if dyspnea, massive ascites, greater than 3 liters, hydrothorax.